Okay. Hey, you guys have smartphones on you?
Yeah.
Cool. Can you do me a huge favor? Can you go on the YouTube app and search Fresno State Premedical Conference and see if you see a live stream?
Okay.
Okay. Sounds good. Hey, Kev, I think I got broadcasting going on. I just need somebody to check on their laptop and Science 2, see if we have a live broadcast. Go YouTube and just type Fresno State Premedical Conference.
Yeah, we got it.
Is it live feed?
It's like the
Yeah.
Nice. Whew. All right. Yeah, we're good on the live broadcast. We got it going.
it's a little behind.
What is it?
It's a little behind.
Yeah, it's 30. It's a 30. I put a 30-second delay on it.
Okay, so I have my camera. What do you want to do?
Do you have a program?
A program?
Yeah, let's go get a program right now.
Do they have a radio?
I'm not sure. If you distribute it, you should have one.
Oh.
This is the most important. This is just 4 minutes.
Actually, it's fine. Those must be over YouTube right now. This is the
Cool. So let me send you the email right now.
So we need to open this one up, right?
Which one? The one I sent you?
Yeah.
Yeah. So again, 2 files are in it. The bigger one is his main keynote speech. The smaller one is
See if I can find it.
Okay.
Have you logged into the live link or the live stream yet?
No.
Okay. Try doing it just
So this room comes with one, but not the other rooms that we care
yeah.
about.
But this one we need it because this is where I got the camera set up in there.
All right. Keep it there. Did you bring that?
Huh?
Power source?
Yes, I did. Right here.
And here, just keep it in there at all times. Wait, is it already recording?
Yes, it's live right now.
Okay. Did you find out how to delete them?
Yes.
All right. This better not be part of the conference. I'll just email it to you. Come here. Do you have Firefox open? No, you do not. What is wrong with you?
Let's check it out. Hey, you say you logged onto the live stream, right?
Yeah.
Do you think you could copy the URL and text it to me real quick, please?
Yeah.
Thank you. Just let me know when you're ready. When I get my number.
Okay, so Fresno State talk. So megabyte, kilobyte, which is bigger? Megabyte.
Megabyte.
All right, cool. Just making sure you're on it. So the megabyte will be the main talk.
The main talk and the kilobytes, the one for the
Yeah.
second session, right? Okay, got it.
Sorry, I know that's the after. I did on the internet.
That's fine. I just need something where you can click on and it pops up. You have the copy of our speech, correct?
Damn it, I was just at time, so I can get it.
Okay. Yeah.
So, I don't know.
I could see it.
Right. It's kind of interesting.
Yeah, he does.
Crazy.
Well, fantastic. Seattle. Haven't visited Seattle yet. It'll be a good excuse to get up there.
I did my music.
Yeah. And how are your other kids? Your daughter got married? I think I met him last summer.
That's really funny.
What time does this start?
9.
Right.
Nice.
So we'll start getting an inflow of people. I'll be right back.
It's taken me a long time to come to terms with Fresno, but I pretty much have, especially after we house sat up in Oakland, in the Oakland Health, beautiful house, for 3 weeks this summer. And I mean, it's nice and all that, but you have to plan every move. If you want to go from A to B, it's like, what time is it? Or forget it, it's impossible. It'll take you longer to get from Oakland to San Francisco than it'll take you to get from Fresno to Oakland.
I've been there.
It's insane. And just the general impaction, just the mass of people around you is just hard. I got that depression. So easy.
15 minutes in.
Yeah, it is. I agree. However, the air is bad, and climate change. The summers
Seems like
oh, I don't think it's normal. I think it's just going to keep getting hotter and drier. Which is interesting why the governor is planning for floods. Because he sees, okay, vegetation's killed off, and then you get a huge rainy season, and nothing in the
Aside from walking around.
yeah, you just wonder if that would be dependent. I just wonder if that's
That's right. The whole economics of the region. It's scary.
It is.
Trying to confuse.
Well, yeah. What else could we do?
Just like sad.
How about you?
You can say
Oh, gosh. Things are really. Dan forgot his. He taught. He taught one year at Churchill. He did it. He did the new teachers, the worst kids. Isn't that right? And he did it for 1 year. He's standing there and he's got the second-year contract and saying, I don't have a science. I'm going to go get a master's. So he goes and gets a master's. And I gotta say, Fresno State nurtured him. He wrote, he got the best thesis. This is in English. And they how new technologies in the web can be employed, wikis and all these. Yeah, I did. Yeah. How all these new technologies can be used to teach, and that's what the kids are into, and that's what they. So you've got a built-in motivation factor there from the technology to use it to get it right. And the one English teacher said it was the best thesis he ever had. And told him he's got to get a PhD. So he looks at programs like this. He finds one in Clemson. It's called, it's a full ride.
We will let you guys know I received the file. I have it loaded on the computer and ready to go.
And it's funny, Clemson, because Jeff Appling, who's now vice
Yeah, I got the
president,
file. It's loaded and ready to go.
on graduate studies at Clemson, was my co-author when we did a little city on teaching chemistry, called Discovering Chemistry. We published it. It's nice graphics and challenging questions and all that. But, he's getting his PhD, and Sam is graduating.
Kev, I also need you, please, bring this.
Is now
Maybe I have the end.
working at the Homeless Premedical Conference in San Francisco. He lives in Oakland County. Finally got a nice place. There's west of Crave. But yeah, it's got a great amazing, very nice. Yeah.
All right, they're loaded up and ready to go. So I just want to make sure they are. So I got this one for this one main speech right now.
Okay, so we're going to do the other one first. It's called Building a Fire.
Here's.
Okay, so I'll deliver that one first. Is there anyone going before me?
No, it's just
Okay, so we can just go ahead and pull that up, and then when I'm finished with this one,
it's just me. I'm sorry. Me and Kevin will be going to a little speech before you, and then
Okay.
I'll introduce you.
Okay. Cool.
So you're going to be doing both, and building a fire, and then the Fresno state.
That's right. Yeah, this one's real quick, and the other one will be
Okay.
about 20 minutes or something.
Sounds good.
It's gonna have until what 10 to 10.
Yeah.
I'm make sure I respect my
10 o'clock.
audience.
Yeah. So we got until 10. Yeah, I think we got everything loaded and cameras right there. So.
Okay, great. Go out and use the bathroom.
Okay, sounds good. Yes, can you come here and look at the screen? Tell me, is there any shadow or anything right there?
Yeah.
Does it look dark? Looks good?
Yeah,
I
that's
can't-
fine. Yeah, that's
Yeah,
good.
it's
You
just-
can look to that. Yeah,
Oh, okay.
that's better.
Okay, good.
That's a lot better.
All right, that way, I just want to get a shot where we have this.
Yeah.
Oh, we're live on YouTube, Dr. Frank, for people that can't come to the
What?
conference.
We're what?
Yeah,
No kidding.
What is
Yeah.
phenomenon?
I set it up. We're on a live broadcast right now. Anybody that's reached the Fresno State Med Conference will be able to listen to our conference. That's over here. The camera's right there.
Oh, there's the camera.
Yeah. So I just wanted to get a shot right here, so wherever Dr. Witt's talking into their PowerPoint.
That's great.
Yeah.
Yeah. Awesome. Didn't even know you could do that.
I had to pull some strings for this. But I learned it quick enough.
Oh, that's awesome. Cool. So when are we going to bring them in?
Let me see. I think at 8:50 we should start bringing them in.
Keep your comments short because there's not a lot of time that he has for what he has to say.
There's not a lot of time. He's gonna give a big talk.
Well,
We
I mean,
we plan
I
like
know
a little
how-
welcoming speech, like 10 minutes.
I would say less
Less.
if you could.
Okay. And then
Remember,
yes.
they came to hear him,
Yeah.
right?
Yeah. I know.
Okay.
Hey, Shola, what's ETA on people coming into UBC? How much time before we start letting the attendees in?
taking them inside?
No. I'm saying, what time do you plan on letting them in?
Christian, I'm bringing over the script right now. We should start bringing people in now.
I'm leaving this row open for all the guest speakers and everybody else can fill out. So all guest speakers will be in the front row.
Ray, do you want to start getting volunteers to herd them in?
Let's have them when we come into one time. We'll just direct them down the row.
That sounds wonderful to me.
So let's not open that one. Let's just open this one. We'll just direct.
That was
You want me to go down again?
Hey, what's the room we're sending the overflow to?
194, then signs 219.
Okay, we got laptops in there
194.
We have 2 laptops. What do you have 2?
because one for the live. Forget about this. This is for the live streaming so that people in the other conference room can see the.
Okay. I have a
keynote.
laptop. Lucy has a laptop. So
Okay, I need. Do we have room? Do we have laptops in the other 2 rooms of the overflow?
Did you get the first one in the LSAT stuff? I couldn't find it.
Can you repeat that? And the other room, is there a laptop in the other room for overflow as well? UBC 191. No, I'm inside the conference room. Which room doesn't have a laptop? Huh?
I have a laptop.
Is it VGA?
It's a Mac.
No.
No.
Laptop, 194.
What? Okay, we established we got 194. What's the other room? Do we have it in the other room? We have another room for overflow.
Science 2109.
Do we have a laptop in Science 2109?
I'm gonna find out right now.
Where's he at?
You would tell me your shoes.
Ah,
You good?
yeah.
Do you need us to help you out with it?
No, he has a trophy. I don't know what we're doing that today.
Oh.
Hey, are you on your way back already? You have the package we're handing out to Dr. Frank, correct? Make sure you bring the package and hurry back up because Dr. Frank wants to start bringing in the people. He wants to keep us short and give Dr. Whitman. What happened? Yeah, I got the script. Emailed you what? The script? No, I printed one out, but I can email it to you right now. Yeah, unless you want me to send you one, you can print it. I'll print it right now from my phone. It should be printed out the house printer. Okay. Yeah, I printed 4, but I don't know why I lost the 3. Or I must have left them at home. Okay. All right, get back ASAP. Cause we need to start. All right.
Is someone bringing the kids, or do you want one of us to?
Huh?
Come?
I think we'll bring him in.
Okay.
Yeah.
Let me know when they get built, and then we'll start putting them in.
What do you think about the program?
Awesome. All right. Really awesome. Look at these pens. You guys went all out. Very impressive, I have to say.
Hopefully UC Davis will hear about us.
Look out, UC Davis. We're coming. You gonna let them in?
Yeah. Okay. That's what I'll show. Hey, Shelly, can you please start letting the attendees in, please?
Where'd you get the walkie-talkie?
We bought them yesterday. No, we just got them for this. We need them for events. Like last time when we did the health and wellness fair, everybody was everywhere, so
Right.
we got them. They're very useful when we have big events like these.
Wow. This is great.
I reserved all the front row for all the guest speakers. So.
Okay.
Wait, should we start moving the?
Yeah, let's start laying them in. Yes, I need you to go on the internet, open it up to YouTube, and type in Fresno State Premedical Conference, and you should click on the live feed. Yeah, yeah. Okay.
See, sir.
Huh?
I'm just trying to think I can speak on the speaker and then run the slides too. And move this
Oh,
over.
you can use the mouse and just walk and click.
Oh, I see.
You just walk because it's like a click, so I just use it like a pointer and I just click and I'll move on to the next slide. Don't just scoot down all the way down, all the way down. Excuse me, guys. If you guys have any space, you guys can scoot all the way down to the road so we let the people coming in fill up the gaps, please. I really appreciate it. Thank you. Go ahead. Okay. Well, the speakers are here for the morning session. Not all of them will be here. But if you have any speakers, just let direct them down this way. Keep down when we get to the overflow.
The next row?
Yeah, 194. 194. If it's one. Okay, everyone, 194, we're sending overflow down to your room. Okay. Okay. Let me know when you guys have full capacity at 194, 109. Okay, I guess we'll get started. Hello and welcome to the Fresno State Premedical Club's Inspiring Tomorrow's Health Leaders Conference. My name is Christian Sarabia and I'm the Vice President of the Fresno State Pre-Med Club. Before we begin, I'd like you to join us in giving a round of applause to the outstanding students who are here today as volunteers to help us make this conference as successful as possible for you all. We really appreciate all of your time and effort. We would also like to thank all of the speakers who willingly and generously donated their valuable time to inspire all the health leaders of tomorrow. Over the next few hours, you will have the opportunity to hear and talk to a variety of leading healthcare professionals, medical school admissions officers, and college faculty who can shape and help you decide the best career path for you. However, most of all, we hope that after you leave here today, you will leave inspired about healthcare and see that going into medicine is a realistic dream that we can all achieve.
So I'd like to tell you a bit about who it is that we are. I'm Kevin Mathima, the Premedical Club President. This is Christian Sarabia, the Vice President. And the Fresno State Pre-Med Club is an organization that includes members from various different pre-health backgrounds and majors. We come together to provide networking and health work, networking opportunities for both our students and as well as the people who help us. We help them reach out to other people in the area.
The Premedical Club's intentions are to educate, promote, introduce, and assist pre-health students in academics, medical school admission, and establish long-lasting connections with innovative and leading healthcare professionals. Our targeted audience are students in the Central Valley interested in healthcare that come from various cultural, gender, racial, and ethnic backgrounds. We targeted universities, community colleges, and high schools throughout the Valley in order to achieve our goals. Our aim is to impact health education, boost the diversity in healthcare, and of course, inspire the health leaders of tomorrow in the Central Valley.
Before we begin the conference, we would like to inform you of the schedule of events for the day and how the conference will proceed after the keynote address. The conference is broken up into 4 different time slots. During each time slot, there will be multiple workshops occurring at that time throughout the campus in 3 buildings. So please refer to your program in order to choose which workshop you'd like to attend, and make sure you follow your campus map on the back to find out the location of these buildings. Going into medicine is not an easy road to take. You will have to endure some of the most difficult tasks there are to reach your goals. And it is in times of great difficulty that we find a person who goes above and beyond to ensure that we achieve our goals. This person is rare, and this person pushes you to be the best that you can be. Sometimes they are the person that you least expect, but they are there for you when you need them. They're there when you need them for assistance. Soon, you take note of this person and realize that they deserve recognition for what they do and for who they are. Which is why, with great pleasure, that the Fresno State Premedical Club would like to award Dr. David Frank the Outstanding Advisor Award.
Oh my God.
That's very nice.
You do a lot for us. Appreciate it.
All right, thank you.
Our keynote speaker began his surgical training in Seattle, Washington, where he completed as chief resident of general surgery. He then further specialized in plastic and reconstructive surgery at UC Irvine Medical School, where he completed as chief resident. In his 32 years of practicing medicine, he has served as medical director of pediatric plastic surgery, director of cleft lip, palate, craniofacial deformities, interim medical director of the special medical group, and as assistant professor at Loma Linda Washington University. Please help me in welcoming your keynote speaker this morning, Dr. Peter Witt.
Well, thank you all for showing up today. You're braving a early Saturday morning to hear a talk on surgery and medicine. I thank Dr. Frank for asking me to come here. We actually go back a little ways. And he's near and dear to my heart because he took my son under his wing at University High School. My son graduated in the first graduating class there. And gave my son a real love of learning chemistry. And so my wife and I are going to be forever grateful for that. The way this works is I'm going to give actually 2 quick talks this morning, and then subsequently around 11 we'll be giving a breakout session. I've invited Fu Tran, who's a surgical resident, to come along with me, and we're going to be just basically loosey-goosey, kind of answering questions about the process, and we can tell you about how we got on the paths that we took.
Yes. Okay, quick.
So this is called building a fire, and that's kind of what you're doing. People in this room are kind of building the fire as you approach the medical school admissions process. And another way of looking at this is learning how to learn for a lifetime, which is kind of what medicine is all about. You never stop learning. You're always kind of going through a process of what you're currently going through. You know, fire is built for a reason. And so the question I have for you is really, what are your reasons for wanting to do medicine? They could include the following. You build a fire for light, warmth, and survival. What are your reasons? I think you ought to think hard about this because it is not an easy path. It's a difficult one, but it's a very rewarding one. And you have to start by taking your own pulse. Are you really interested in human biology? I mean, I think that's a key question that you need to think about. Because when people ask you, why do you want to be a doctor, it's not enough for you to say, I want to help people. You can do that in any profession, seriously. And I think if you don't have a strong underlying love of human biology and fascination with that, I just wonder about the long-term commitment and passion. Do you need a fire? You have to ask that question too. If you have to ask your mother, should I be a doctor? The answer is clearly no. Right? I have people come to me, students, high school students, college students, should I be a doctor? And I always say quickly, no. In other words, the student that comes to me and says, I'm going to be a doctor, I would bend over backwards for that person to help them achieve their goals. But this is something that you have to be spread eagle in terms of your commitment and going full bore, because it's not just getting into medical school, it's going to be the years after that, where in my case, working every other night on call for about 8 years during the training process. You have to kind of be willing to put a lot of things on the back burner. And that may mean interests and people that you love and so forth. So you need to think about those things. So is there a question that you're interested in answering? I mean, are you interested in cancer biology? Are you interested in chemistry as it relates to human biology? Or is this just like another pathway? In other words, you're going through college and then you decide that you want to spend another 4 years studying because you're not quite sure. Can you sustain a fire? Do you have the desire and the discipline to go to medical school for the reasons that we just talked about? Is there a suitable site for your fire? You have available fuel, you have the logs that you need or the sticks to start with. You have to make sure that there are no overhangs, obstacles that might prevent your fire from burning bright. And you gotta have good ventilation, you gotta have oxygen. And if you catch my drift, I mean, you need to be around people who can help you and nurture you and mentor you. You have to ask, can you go to medical school in this place? And what I mean by that is that, you know, it's important that as you approach this process, you're looking at the different schools, and the kinds of questions that you might want to ask would be, is there financial aid available at this place? Might I be a candidate for that? This is a non-trivial answer that needs to be, a question that needs to be answered overtly. And the reason I say that is that we have med students that are coming through right now that rotate with me at Children's Hospital. And the average debt that they're having right now is around $250,000. And that is just unconscionable. It's something that you all need to think about before going into this. Is there a willingness of other students in the environment to be mutually supportive? That's important too when you make your interviews, to be asking questions. Are people happy here? Or are they just kind of slugging it out? When I made my interview circuits, it was really interesting, the variability that you find at different medical schools, where some schools that you would revere, the students were depressed and they were just kind of overwhelmed. And there were other environments where the people really seemed happy. Does a medical school have a clinical or a research focus, and does it matter? I mean, I think you all have a personality and you may be drawn to research or maybe more drawn to clinical medicine, and certainly schools are that way too. And then, are there physician mentors available for you? Is the curriculum of a given environment novel or interesting? For example, at Case Western Reserve University, they have an interesting method of teaching, and they've always been kind of on the forefront of changing curricula. Back 50 years ago, they went to a non-traditional method of teaching by systems, which pioneered the way for many other medical schools to follow. And there are different kinds of pathways that different schools take. And then you want to have fun, because that's part of it. So starting your fire, first of all, you got to collect all the kindling. You want to focus on a major that excites you. Let me underline that. It's very important. Don't just do biology or chemistry because you think that's what they want. I was an English major. I wrote my paper on Shakespeare. And it's important that you do something that interests you. You can get your pre-med done and still major in classics. So just keep that in mind. You don't have to do what everybody else does. And in fact, the med school admissions committees like that. So when I interview, most of the time, they're really interested in hearing about when I made pizzas in Italy one summer. And I had a friend who told them about his pet boa constrictor, and they spent hours laughing about it. I mean, you catch my drift. You want to be doing something that excites you primarily. I think it would help if you have a friend who's in medical school who, it might be helpful anyway, too, that you can talk to kind of get some advice along the way. And then identify sources of funding if that's available to you. As I said, that's a major issue right now with tuition being what it is. I think David, I think Stanford Med School this year is around $65,000 a year for tuition alone. So that needs to be taken into consideration. You can buy a house for that. And then you need a match, obviously. Strike the match. Go for it. Have a well-defined plan as you're going through this. You want to study abroad? I think it's a good idea. I do. And I think you can do it if you choose your classes properly and it's an enriching experience for you. How are you going to finance this? We've already talked about that. And then consider visiting medical schools. You've got 2 great med schools, 3 really, 4 really. And right here in the Central Valley, we're 3 hours away from Stanford, UC Davis, UCLA, USC, UCSF, obviously. It doesn't take much to go up there and kind of look around and talk to students and see how they're like. So once you get your fire going, you want to kind of nurture this fire. You want to get it to build and roll. So obviously that means you got to study. I mean, you're going to have to say no to a lot of things in order to meet your goal. Hang out with physicians if that helps, if they can help you along. Consider research. I think that's a good idea if you're really interested in it. And then attend meetings like what you're doing right now. And then as you move along, you want to kind of add logs to your fire. If you're interested and you have the gumption, write an abstract. See if you have a teacher or mentor who can help you do a paper that you might be able to present at a national venue. That helps. It gives you confidence for one thing. But also, I think a admissions committee would look at that and say, this kid has gumption. And then think about, presenting either locally, regionally, and I've had medical students and even college students present nationally before with me at various club meetings that I attend. It's okay for you to take a year off. That's not the end of the world. I mean, I hope I'm not speaking heresy here. I think in general, if you have a plan on how you're going to utilize that year, it's not going to count against you, unless you're just kind of drifting and not having anything to do that's meaningful during that year. And then the fire tenders. Don't listen too much to what other people are saying. I would listen to Dr. Frank because he can give you the straight scoop. But when I was in college, I remember some of the worst advice I got was from other students who really didn't know how the process worked, but were kind of more paranoid about their own concerns about getting into medical school. It wasn't really good advice. And don't let that deflect you from sustaining an effort and doing what you're doing. MCAT preparation is important. Duh. I mean, obviously. But you'll hear people say, "Oh, it's either know it or you don't." Not true. You can study for that test, and you should. And you should plan on 3 months of concerted study for the MCAT because it is important. Case in point, last time I spoke here, I brought along a medical student who had good grades, but not great grades. But she aced the MCAT, and it was her ticket. It's what got her interviews. And once you got the interviews, the whole process changes a little bit. They know you can do it quantitatively. Otherwise, you wouldn't be interviewing with them. They want to know, and they're thinking at that point when they're interviewing you, would I enjoy training this person? Is this someone who has a future in medicine? And so it takes on a whole different complexion. Okay, you want to maintain your fire. So during this process, and it's not too early in your second or third year of undergrad to start thinking about your personal statement, what your values are, why you want to be a doctor. Write it, rewrite it, have someone critique it, rewrite it. Pass your manuscript back and forth with someone that you trust so that you can hone that. Add some railroad ties to your file. So here you want to get letters from professors whom you know personally. It helps to have direct knowledge of somebody so they can write a meaningful letter for you. And then share your fire. Once you get into medical school, you're kind of under an obligation to help other people to reach their goals as well. It's not just, I'm up and pull the ladder up. So keep that in mind. And then the importance of desire, which can't be underestimated, because in the end, the thing that is going to enable you not only to get into medical school, but then to pursue your career dream. The only thing that really, the two things that matter the most are your passion and your commitment. And everything else doesn't really matter that much. Remember that as you go through this process, even Ted Williams only batted 400. It's unlikely that you're going to apply to 10 medical schools and get into all of them. The numbers are not necessarily with you on that. But just remember that you don't have to bat 1,000. And then don't get burned. You want to make sure you pay attention to the deadlines and don't slack off your last year. I had a friend in college who was really qualified, and he got into a bunch of med schools early in his senior year, and then goofed off. And lo and behold, he got a D in a biology class. And the school where he wanted to go, at that time it was Cornell, they called him on the carpet for it, and he was sweating. So that's just something to remember. Once you get in, don't just throw the book. Know yourself. Okay. I'm not sure how I get to that. Okay, shifting gears here. I'm going to go Mach 2 with my hair on fire because there are a lot of slides here. But what I do is pediatric plastic surgery, and it is really cool. I hope that one person in this room might get excited about doing this in the future. And this is just a quick reminder to let you know this is not what I do. Okay, I don't do any cosmetics. A lot of people are into that. You see it on TV and reality shows and stuff. But what I do is basically operate on babies that have birth defects. So that includes cleft lip and palate, craniofacial, hand anomalies, vascular malformations, and things of that nature, and then trauma. And this is just a quick slide to remember that you should never really listen to a plastic surgeon. Don't trust what you hear all the time. This is obviously a Photoshop situation. Okay, so what do I do? Starting, my expertise is in cleft lip and palate. By the way, at my second session at 11 today, happy to answer questions about this, talk to you about coming to visit our hospital, or maybe even come to surgery and so forth. But, these are really common anomalies, so about 1 in 600 live births. And this is a pretty typical example of what I'm talking about. A bilateral complete cleft lip and palate. Here's a bilateral as well. You probably see pictures in the newspaper from Smile Train or other organizations, Operation Smile, kids that have these deformities. This is what my area of expertise is in. And it's really cool because it's not just a surgeon riding in on a white horse to save the day. It's multidisciplinary. So I work with all kinds of really smart people in other disciplines, including a speech pathologist. And by the way, that's how I made my career, is I tagged on with a really smart speech pathological efforts on post-palate speech dysfunction, and kind of built my career around that. And it involves all of these different specialties. I won't go and name all of them, maybe you get the drift. It's about 10 different subspecialties that are involved in the care of these children, because it's not just one simple deal. It involves speech, it involves hearing, it involves facial aesthetics and psychosocial stigmatization issues and so forth. Audiology and speech are critical to the stuff that I do. And then we're involved in treating, diagnosing, and managing these kids. This is that baby on the right, and basically 3 operations in the first year of life. And I still get Christmas cards from the family. He's actually now in college and doing great. Okay, I mean, you get the idea. This is the kind of stuff that I do. And it's really fun, rewarding surgery work. It's, in my opinion, the best of plastic surgery. So you can see it's obviously not perfect. If you look at the photo on the right, look at the nose. You see there's one little kind of shiny dot there. There should be 2. The dome of the nose, there are 2 of them. And so the fact that you only see one with that right light reflex indicates that the symmetry is not totally good. So we still have a ways to go on for repairs. And, you know, it's not perfect because there will always be scars. But the idea is we want to minimize difference in psychosocial stigmatization. This is a child that came from Korea and was unrepaired, and we had to do everything at once, the definitive cleft lip and the palatoplasty at the same time. Okay, so I think you catch my drift here. One of the problems with cleft palate is, you may know, the palate's the roof of the mouth, and if you have a hole in that, then the problem is not the inability to eat, and it's typically not stigmatization. The problem is that you can't speak right. Okay, if you don't have a way of separating your oral and your nasal cavities, then you end up with maladaptive patterns of articulation and speech, hypernasality, facial grimacing, and so forth. And it's very morbid. Okay, the studies are incontrovertible. It actually is worse to have the bad speech than it is to have a scar on your lip. It turns out that if you speak poorly or you're unintelligible or you sound funny, it sets the tone for other people's interpretation that you're just kind of dumb. And that's not true. These kids are not dumb, they're normal, and they want to be normal. Okay? And so I spent a greater part of my life in researching and helping to treat the phenomenon of post-palate speech dysfunction with surgery, and then following that with careful studies, quality control with my speech pathologists. And so there are some operations, I won't go into the details because it doesn't matter, but various operations that are used to treat them. And this is kind of the stuff that I do on a daily basis out of Children's Hospital. Now, I have a goofy practice. It turns out I'm also a board certified hand surgeon. And so the children oftentimes are born with craniofacial problems and also hand problems synchronously. Why would that be? Well, what I'm getting at is in embryonic development, the development of these two systems happens around the same time. And so it's not uncommon to see the same thing. I always loved hand surgery, so it seemed logical extension to me to also be a hand surgeon. So if a child's born without a thumb, we'll make them a thumb. If a child is born with webbed digits or extra digits or crooked digits or whatever, that's what we do in hand surgery as well. And it's really cool because we're talking small field surgery. You get to work under the microscope. You have to know your anatomy. You have to have exquisite knowledge of anatomy. And there's flaps and there's an aesthetic aspect. I mean, think about your hand. You know, it's like your face in the sense that you position it in space to do things. And so it's, in a sense, it is cosmetic surgery. And I look at it that way. You want to restore the function and the form as well. And so these are some of the problems that we treat in hand surgery. Webbed fingers are pretty common. We see this almost as commonly as cleft lip and palate. And it can be simple or complex. The bone can be fused, or it can be just simple skin involvement, proximal or distal, complete or incomplete. And it often is kind of cool because you have to work on the tendons and the neurovascular bundles at the same time. So it involves all this stuff. So both the aesthetic and the functional aspects. You can see here the extra bone and the way that the bones are kind of fused, the distal aspect of the hand there. Kind of a crummy picture. I needed to breed this from my presentation, but the idea there is that you can see the digits separated. It's not just taking a knife and kind of splitting things down the middle. It's more complicated than that. And a lot of surgery, a lot of about 3.5 hours of surgery with skin grafting. This has to be one of my favorite operations, the thumb. Think about your thumb. Your thumb is really important, okay? Really important. How is it different than your fingers? Well, for one thing, it's out of the plane of the palm, right? It's opposable. So you have the pulp of the thumb that faces the little finger like that. That's called opposition. And there are developmental biologists that believe that this is the reason why human beings are different from lower animals. Is the opposability of the thumb enabled the brain to expand in the way that it did for us to be human beings and to have cognition, self-awareness, and this sort of thing. So it is a really important structure that represents about 70% of the function of your hand is your thumb. So if a child is born without a thumb, that's a big deal. You know, they try to pick objects up by scissoring like this. And so what we do is a procedure called pollicization to create a thumb. And the idea there is to use the index finger and move it over, recess and rotate it into a position in which it will serve the function of a thumb for opposability, grasp, key pinch, power grip, lateral pinch, all that stuff, all right? So you're thinking, ooh, what about that index finger? Guess what? You don't need it. I could right now take any one of you and chop off your index finger, and tomorrow your brain would simply move over to the long finger to do fine motor activity, all right? That finger needs to be in the position of a thumb for these babies. Plus, by doing this operation, you preserve sensation, which is really important to have protection, protective sensation of the digit. So this is like a granddaddy king of all operations on the hand. It's under the microscope. You have to know your stuff, do it under a quick 2-hour tourniquet run, drop the tourniquet, and then put everything back together. So tendons, nerves, arteries, veins, the bone, shortening, fixating the bone, and then doing the skin reorganization. So it's a wonderful operation. Another example here, and afterwards the kids, they do really well with minimal treatment. You're operating on a baby that's 1 year old, and within age 3, they're able to use that new digit. Absent thumb is, in my opinion, like I said, it's right up there with bilateral cleft lip and palate. It's great operations to do, really exciting. Okay, the third broad category of things that we do are vascular malformations or hemangiomas. And these are really common. 10% of all babies have them. Okay, and so they come in just like a faucet at our hospital. They're just way out there. Hemangiomas, what does the suffix oma mean? You hear the phrase carcinoma, sarcoma. Well, oma means proliferation. It means that the cells are dropping into mitosis and they're dividing, there's DNA synthesis. There's proliferation, okay? And a hemangioma is a benign tumor of infancy. And we don't know what causes them. We have some various hypotheses about FGF8 or whatever isoforms might be responsible for this, but we don't really know. The thing that's interesting is they proliferate, and then for reasons we don't understand, they also involute. So rapid proliferation, then starting around age 1 or 2, slow involution. By age 5, many of them are gone. Which leads to the general dictum that we don't do anything about them. Leave them alone, they'll go away. Well, in this case, they don't go away. When they do, they end up leaving a pancake on the patient's face. And that's why they come to a plastic surgeon. This was a really nice family that came to me from Illinois, and they had been to a whole bunch of different doctors who had told them, don't worry, it will go away. No, it won't. And you can imagine every time this mom took the child to the grocery store, all kinds of looks and horrible things that people would overtly say to her. And it was an operation. It was about a 2-hour operation that I was able to remove the whole thing and close it up, and they were on their way, and I still get a Christmas card from them. Another case, I converted this to a cleft lip and let the resident do it. It took about an hour. Another case here, little babies are obligate nasal breathers, and this child couldn't breathe and was in and out of ICUs, and this was a quick operation too. How am I doing?
You're good.
Okay, good. I want to respect my audience, so I'm not going to go over, I promise. So that is one category of vascular anomalies that we see in children. Another one is called malformations. Unlike a hemangioma, a malformation does not proliferate. They are present at birth. They don't develop after birth. Okay, do you guys remember Gorbachev? So he had a splash on his forehead. That's called a vascular malformation. That is something that typically you do treat early on with a laser. So laser can be helpful. It's all red, and it can avert some of the long-term bad consequences of those things. You know how laser works? It's basically light, a thermal energy that interacts with the blood vessels, fries the blood vessels, but the thermal relaxation time is such that it doesn't injure the surrounding tissue. So the magic of it is that you can improve them and treat the blood vessels without injuring the surrounding tissue. So you can do this without scarring. And this is a condition that some children have called Sturge-Weber, which is an extensive involvement of this malformation. And what it does is that the slight increase in blood flow in the skin induces a secondary overgrowth of the tissues underneath it. So the lip begins to get huge, the skin becomes leathery and thickened, and even if you biopsy the muscle or even the bone underneath it, often you'll find some evidence of the vascular malformation. So these can be very problematic conditions, and we treat this in pediatric plastic surgery. Okay, here's an example of what we call a venous malformation, and I show you this only because it's kind of interesting that it's the tip of the iceberg. It's not just on the tip of the finger, and you have to talk to the parent ahead of time about that, because otherwise the kid comes out of surgery with a long incision that they weren't expecting. But they are like little pieces of grapes that are friable, and they kind of break easy, and they bleed, and they're everywhere. They track right along the neurovascular bundles of the digit. So Basically, that child I had to unzip into the palm in order to get everything out. And you can see the digit there. I mentioned Gorbachev, and that's just the doodad that he has on his forehead, and that's called a vascular malformation. Okay, this was a lady. Now, I do kids only, but this was a lady who had been jerked around by a whole bunch of different care providers. You guys see anything weird about this? I mean, obviously that ear is huge. Let's see if I can go back. Well, I can't go back, but the bottom line on her was that she had what's called an arteriovenous malformation, so direct connection between the artery and the vein. And she went to bed every night and she heard this whoosh, whoosh, whoosh. Can you imagine every night hearing that sound of the blood there? And so we ended up having to resect that whole thing and reconstruct the ear with a costochondral cartilage graft. This is a child with a so-called cystic hygroma, which is a lymphatic malformation, twisted capillaries of lymphatic vessels that are kind of underneath the skin. When the children are born this way, they have floppy airways, and this can compress on their trachea. It can actually be life-threatening. So they come to surgical attention. Okay, what else do we do? Well, we do microsurgery. What do you guys see here? Huh? Okay, one person. Okay, he says the chipping of the bone. Is that the dot that you are seeing? Okay, that's good. What do you see here? Okay, so the first picture was that of one arm, and the second picture was that of this arm, which is a both bone open fracture of the forearm complex. This was a girl who was out with their friendly Doberman pinscher, and they found her down in a pool of blood with a hemoglobin of 3. She almost died. The dog just about killed her. Ripped off all the musculature on the forearm from the elbow to the wrist on both sides. Broke the bones and devascularized the hand. So our predicament when she came in was that we were on the verge of doing amputations. But instead what we did is we went to surgery. And we did it in 2 stages. The first night that she came in, the first night we took her in and took long vein graft from her legs and revascularized the hand from the proximal forearm down to the wrist. So got the hand to be alive. Plated the bone, so fixated and reduced and fixated the bone fractures, and then put the pig skin on top of that because all of the muscle was gone. And then we went to bed because that was a long procedure. And the next morning we got up and I got my friendly colleague, who actually was a real good friend of mine, also a great microsurgeon, took her to surgery and then flipped her on her back and pulled up both latissimus dorsi muscles. So he was on one side, I was on the other side. Pulled up the muscles and then divided them, closed up the wounds, and flipped her back over so her arms were out like this. And here's the 2 muscles. Now, you know the latissimus on the back is a huge muscle. You don't need it. You know, it's only good for the terminal 5 degrees of extension of your arm up over your head, or when you're pushing off with your skis. So it's not a critical muscle, and we use it in reconstruction all the time. Then we got under the microscope. We got 2 microscopes in the room, and we went at it. And so we hooked up the arteries and the veins and the nerves, and then revascularized the muscle that we transplanted, reinserted the muscles proximally and distally, and then took skin grafts and plopped those on top of the muscle. This is the patient about 6 weeks later. It's not perfect, but you can see the muscle begins to kind of contract down as it sort of kind of shrinks down, because when a muscle is denervated, you always lose some of that mass, but it can form very nicely to her forearm. And she developed the ability to flex her hands. But she didn't have the fine motor because she had lost all those tendon musculoskeletal units. But better than doing amputations, we think. We also do lumps and bumps because a finite number of kids will have these dysplastic nevi that can turn into cancer. And I know this firsthand because I have 5 kids and my 3rd son had cancer of the liver. So it does, lightning does strike, it does happen. And so these conditions, when they happen, they're pretty devastating. These patients are often referred to us to have these things removed to eliminate the cancer risk. Okay, facial trauma. This happens all the time. In fact, when I'm on call over at Children's, it's almost every time I'm on call, we'll get fractures, facial fractures. Maybe a kid's playing baseball and the ball hits them in the orbit and they get a blowout fracture, or a zygomatic complex fracture, or a complex, what's called a Lefort fracture, a craniofacial disjunction from a car crash or something like that. So we're often called fixed fractures. Facial trauma, it goes without saying that facial trauma is one of the purviews of plastic surgery. What would you guys worry about with a laceration like this? I mean, what?
Nerves.
Okay, nerves, someone said, and that's really good, really important, because this laceration goes directly through the facial nerve. Think about it. Think about your ability to animate. It's really important those nerves be repaired. A lot of important structures, the parotid gland, the carotid artery down below. So there are a lot of important structures that live in the face. And so in pediatric plastic surgery, we're often called to manage these kinds of problems. About a year ago, I dealt with a pit bull injury where a toddler was toddling around and a pit bull grabbed a hold of the child, clamped down like this, and then shook the kid. Avulsed both the facial nerves from their canal, from their exit point from the base of the brain. And after finishing my operation to fix the kid up, I had to tell the mother that her baby would never smile at her. Never. That's the kind of stuff that we have to deal with. So we're actually doing a big campaign on dog bites right now because they're so common. And the face are the important structures that are obvious, the critical anatomy of the nose, the lip. Think about your lip, the exquisite anatomy of how your lip works. The low and the high point of the cupid's bow complex, the central, the philtral columns in the central dimple, the basilar flare of the columella, the relationship of the lip to the nostril opening, the distance from the midpoint of the lip down to the oral commissures of the mouth bilaterally. These are all things that we have to think about in surgery, because by doing this, you affect that. If I do sew this wound together here, am I going to distort the nose on the other side? So, and in pediatrics, the cool thing, I think, is that you always have to think about the fourth dimension, which is time and growth. You have to be thinking about how's this kid going to look as a teenager. I guess I put this in for a wow effect. Occasionally we'll see this sort of trauma. And what it is the so-called short arm, long gun attempt at suicide, where they drop the arm down. Instead of blowing away their medulla and killing themselves, they end up blowing their face off and not killing themselves. So you get basically a frontal lobotomy, which changes their demeanor a lot. But these are, obviously very difficult structures to reconstruct with normalcy. And it's still, we're a ways away from being able to construct these things normally. For example, he has a ways to go and needs to have some prosthetic devices for his eye that's missing and so forth. And this is just a simple case where a dog bit off the end of a patient's nose. And what I did there was take a composite graft of cartilage from the ear with the skin to reconstruct the normal contour of the nose, the alar cartilage. Show you the burn team only because it's definitely a team effort. It's a huge effort. Burns, the thing that you learn from doing burns, and I'm sure who can tell the same thing, is that you don't want to get burned. It's a horrible injury. And it requires so much effort, not just skin grafting and trying to deal with all the multi-system issues to save their life. And then subsequently, there's a lot of rehab that goes into these patients. We in plastic surgery are often called to take care of burns in the hands. So like in a house fire, a propane flash, or something like that. Children do what's natural, which is to go like this to protect their face. They don't go like this. So we don't see volar burns, we see dorsal burns. And those require extensive skin graft procedures to fix them up so they don't get contracted. You guys ever heard of what a keloid is? You hear that phrase? It's a type of a scar that just keeps on going. The gift that keeps giving. It doesn't, the machinery for wound healing does not stop. It just kind of keeps going. It gives horrendous scars. In other words, let's say that you decide you want to pierce your ear and you're a keloid former, you can get a big mass of scar that forms there. They're very difficult to treat. We get called to take care of those sometimes. I'm just kind of running through some quickies here. We deal often with things like protruding ears, which you think is trivial. It's a trivial operation, but it's not trivial for these children. They come in and they're teased on a daily basis at school. Dumbo ears, all kinds of unkind things are said to them. It's a quick, stupid operation. And within a week, they're back in school and their lives are changed. It's awesome. Kind of heading toward the end of the lecture here, but we also deal with weird and wonderful things like abnormal skull shape, babies that are born with skull suture, synostosis or fusions, and we do big reconstructive procedures where we basically take their skull off, take the skull to the back table, and then do osteotomies, cut the bone, reconstruct it, and then put it back on. And it sounds outrageous, and it really is. It's an amazing thing to see. And a helmet afterwards after the surgery. Okay, so that's what we do a little bit. That's pediatric plastic surgery. It's not the facelifts and all that stuff. Just to end the quickies here, you know, in terms of, Dr. Frank will go over in his lecture about the ideal candidate applicant for medical school. You know, it goes without saying that you'll need to have a certain threshold level of grades. You don't have to be a straight A student to get into medical school. That's a myth. I mean, it helps to have good grades. It helps to have good MCAS, but that's not the only thing that they're looking for. If you have some exposure to medicine and you can show the committee that you really are committed to this over the long haul, that helps a lot. And then the interview and the personal statement are two things that I think you can't discount. I mean, this is really silly, and you know, I'll tell you this. I've been out for 32 years. I went to college at Stanford, and I had a friend that was a great student, had great grades. And you know what he did? This was so stupid. On his application, they asked for a personal statement. He drew a picture of Mickey Mouse. And he got into medical school, but he only got into like one. And they didn't think it was funny. So take these things seriously. And again, the question that they're going to be asking once you get to that interview phase is this someone that I would want to train? Is this someone that would be responsible as a future healthcare leader in our society? And I only say this because it is kind of an undignified process, and it's anxiety provocative, and you can do it. And you have the proper support systems, you guys can do it. So that's it. I hope to see some of you at 11. Are there any quick questions here before? Come on. Yeah.
Why did you choose to go to pediatrics?
His question is, why did I choose to do pediatric plastic surgery? The answer, really, the technical answer will be at 11, because it is an interesting, but the short story on this is that when I was a medical student, I knew two pieces of information for certain. One is that I didn't want to do pediatrics. It was the only rotation that I didn't get honors in. I didn't enjoy it. Number two is I didn't want to have any of my kids. And I have 5 kids now in pediatric surgery. So that just shows you that your pathway can meander and change, and it does change. Bottom line is that for me, when I did my first cleft lid, that pulled the trigger, and I knew I found my way. So there's a lot about plastic surgery I really like. It seemed like a logical extension of general surgery, which I really like. And so for me, that was the way the path went. And you just never know where things go. Any other questions? Please.
Is it hard to see what you do? Is it hard to deal with it?
Sorry?
The stuff that you see and how what children do with it. Is it hard to do and how do you do it?
Okay, so her question is it hard to see the stuff that we see and to take care of the kids that we take care of? That's a good question. You know, the answer is I love what I do, and And it's a personality thing. I mean, I love being able to take a bilateral cleft and turn it into something awesome. It's just really cool when you give the baby back to the mom's dad. So I like that. The hard part is, like at our hospital, there's a lot of child abuse. There's more child abuse than you could imagine, and it makes me angry. And there's stuff like that happens that, you see some perfectly awful stuff that, it makes it difficult to go to bed at night. People taking their little child and dunking it in scalding water. Some parents who have taken a hot iron and burned their child's hand, or stuff like that. And so those are the things that are hard for me to deal with. I was doing a dog bite on a little toddler about 2 weeks ago, in the middle of the night, and the child's face was just all ripped up. And I was putting things back together, but there are going to be scars, and there's missing tissue. And that tissue's gone, it's gone. You do the best you can, try to make things look normal. But one of my colleagues walked in and he looked at the child and he said, parents have to do jail time. That's the hard stuff for me. So I don't know, I shouldn't have inflicted that on you, but that's the answer to the question. One more, we have time for one more. Yeah.
What is the question that you ask yourself every day before you do your job? Like a specific question for your motivation to do it?
So the question is, what question do I ask myself before I go into work every day? I'm not sure that I'm that cerebral. I do try to read around my patients. So I don't know if that answers your question, but in plastic surgery, we operate from the tip of the head down to the toe. So there's always something that I've not operated on before, and that doesn't matter. I've had 8 years of training, broadly trained, and it's principles that matter. It's not necessarily the technique. The technique will always change. The principles of management are always the same. And so I do read in advance of challenging problems. We talk about it among ourselves in our division at the hospital. And so I don't know if that answers your question, but that's kind of what I do. All right, well, thank you very much for your attention.
All right, everybody. So we're going to be starting off. Just give me 1 second. So we're going to be breaking off into our first session. So these are the guest speakers that will be during the first session. You guys have maps behind your program so you guys can see the room numbers, and these are the topics that we'll be offering. So that's it. We will be continuing our live stream for our viewers online in this room. Thank you.
That was very nice of you guys. Totally floored me. I had not expected anything like that.
Technology.